Okay, so we're going to start with our session number one, Genomic Landscape in Latin America. For this, please join me to welcome our panel of speakers, mostly female scientists. Let me note we will cover many topics and important initiatives. So please let's start with Ligia Pereira from Brazil to talk about the Brazilian Reference Genome Project. Ligia, please.
Hello, everybody, and thank you very much for the opportunity to present our genomic initiative in Brazil, and congratulations for being able to put together a virtual meeting at the last time. So could I have the first slide, please? So I'm going to talk about the Brazilian Reference Genome Project, which we launched last December. The next slide. The next slide is just something that we all are very aware of, the lack of diversity in human genetic studies. And I highlighted here how Hispanic or Latin America contribute to only 1% of the genomic data currently available. So the next slide. So just to give a little overview of how the Brazilian population was generated, we were initially 5 million Indians, Native Americans, and then we had a large migration from Portugal, and later on other regions of Europe. And these Europeans brought the largest number of Africans as slaves that came out of Africa as slaves, and from different regions of Africa, like we show here and highlighted here in red. And all these original populations mixed during the colonization of Brazil, giving rise, next slide, to our currently very mixed population. So we are currently almost 210 million people, and this is a plot of genomic ancestry that we performed with a sample of our population with people that self-identified as white, black, or mixed, and it just shows each line is one person with the different percentages of genomic ancestry, African, European, and Amerindian, and we can see how diverse and mixed our population is. So next slide. Given that lack of diversity was something that started being aware in the end of 2016, we decided it was time to put together a genome project in Brazil. And we initially called it DNA of Brazil. And next, as we're talking about low resource settings, and we are a low resource setting for science at least, we decided to take advantage of small groups of Brazilians that are already clinically very well characterized. So when we identified one first cohort, which is this ELSA Brazil, the longitudinal study of the adult health, is the largest epidemiologic study going on in Brazil with 15,000 public servers, and they have been followed clinically since 2008. And so if we look in the map on the right, although they are being followed in 6 different cities in Brazil, if we take the state where they are from originally, we can see that we have a fair coverage of the country. Next slide, please. And next, one advantage of this study is that in addition to a large database of clinical features and environmental and lifestyle from each of the 15,000 participants, The ELSA study also had already collected DNA from those 50,000 individuals. Next. So then the question was funding, of course. And I want to point this out because as we are all in, as we're talking about low resource settings, this was the first time that I decided to go after private funding for a research project. So we figured this was not a project, my personal project, this was a project for the country. So I spent 18 months knocking at the door of several private institutions, and we finally got enough funding from the largest laboratory diagnostic group in Brazil, DASA, and they gave us 3,000 whole genome sequences in a partnership with Illumina, and Google Cloud gave us the cloud space for storage and processing of the data. So with this enough funding, we were able to launch the project and start working last December. So next slide, please. So where are we at right now? We have sent already more than 2,000 DNA samples to the DASA laboratory. Right now, they have 347 in the sequencing machine, another 340 being processed, and they already sent us 365 genomes that we are analyzing. Next one. From these 365, we have been able to look at ancestry already. So we have on the left the ECA, and we can see compared to the original populations, in the blue dots are our Brazilians, some of our Brazilians, and we can see the mixture. And another analysis that we're doing is the mitochondrial genome. And we're finding quite a lot of diversity within those first 365 samples. So we're just starting generating the data. Next one, please. Then it came, the beauty of this story is that once we were able to put the project together with the private funding, then the Ministry of Health of Brazil took over the project, and they are creating a national policy on precision medicine, which has two arms, one in genomics and one in advanced therapies. In the genomics arm on the left, there are two initiatives. One is the population genomics, and this slide had some animations, and so the population genomics started as our DNA of Brazil project, and now it has been renamed as the Brazilian Reference Genome, and this now has funding from the Ministry of Health. And we have another initiative on rare diseases, most like the Genomic England initiative. And the idea is that the genomics will identify targets for the advanced therapies, which will include gene and cell therapy and the development of biologics. And so this, before the coronavirus came up, the Ministry of Health was going to launch this national policy right after Carnival, but the virus got here first. Next slide. So what are our strategy for this Brazilian reference genome? It's to expand the strategy from the original DNA of Brazil. So we want to leverage the investment already made in cohort studies throughout Brazil, so that we already have the clinical characterization of these groups of Brazilians. So this will involve cohort identification, and here on the right I put some of the cohorts that we have already identified, and These will add up to some 40,000 genomes. We would have the harmonization of the clinical data, since each study collected these data, these clinical data, probably differently. And then we would have the sequencing and data access to the data. And what has been proposed, and we haven't yet confirmed, is that the first groups to have access to the data would be the groups involved in the clinical characterizations, the cohort studies. They would have privileged access to the genomic data, and eventually we would open that to groups which included some Brazilian groups. And after that, then we would have an open or controlled access to the international scientific community. And the preoccupation here is that we don't want to be just a data generator and then the discoveries be made elsewhere. We want to participate in generating discoveries from this genomic and clinical data. So in order to compensate for some competitive disadvantage that we may have in terms of resources and the number of bioinformaticians, that's why we're planning and thinking of giving this privileged access to Brazilian groups for 1 year. Next, please. And eventually, in the second phase, we would have to develop some strategy to use the data from our unified public health service to scale up to 200,000 genomes. So Brazil has a public health service that covers the whole country. If they can implement electronic health records, then we would have access to a much larger Brazilian population. And we're also counting that with time, the cost of sequencing will keep going down and will facilitate us having the funding and to get up to those 200,000. Next, please. So I just want now to acknowledge the team that started with the DNA from Brazil, and now we became the Brazil Reference Genome Project. And I'm happy to take any questions. Thank you.
Next, our next speaker is Bernal Esquivel. He's from the Latin American Association of Precision Medicine. He's going to talk about clinical implementation of pharmacogenomics in Latin America. Bernal, please.
Thank you very much. First of all, I want to, it's a pleasure being here. Thank you for the invitation. So can we move over to the first slide, please? So yeah, I'm gonna be discussing with you. First of all, I would like to walk you through what's the ALAMP, the Latin American Association for Personalized Medicine, where everything started, where are we right now, what are we doing in Latin America, and what are we doing in terms of pharmacogenomics. Can we go to the next slide, please? These are my financial and non-financial disclosures. I don't have anything related with this talk in particular. Next slide. So I would like to start my presentation with this video. It's a very interesting video. I would like to apologize for the quality of the video. It's the authentic one, the real one, and as you can tell, it's back in the 60s. It's an interview where a very famous Mexican journalist called Jacobo Zabludovsky interviewed Salvador Dali, and he asked the master where his creativity come from. So it's a very interesting video. It's back in the 1960, just a couple of years after Watson and Crick discovered or described the DNA structure. And the journalist asked Dali, where does your creativity come from? And Dali answered precisely, from DNA. And this journalist asked him, and do you edit? So it's very interesting how in a short period of time, where are we right now? And we are working worldwide, more than 50 countries around the world discussing about genomics, and we were thinking about if we can eat or not DNA. Let's go to the next slide, please. So again, this is the main topics that I will be covering through my presentation. I would like to share with you what's the ALAM and what are we doing nowadays. And also I would like to share with you what has been done in terms of pharmacogenomics around ALM. Next slide. ALM, Latin American Association for Personalized Medicine, was established back in 2014. Basically, we were three physicians that we were trying independently to practice or start utilizing precision medicine in our day-by-day practice. And we started talking and discussing about the different tools that we have around genomic medicine with our colleagues. And we noticed that one of the biggest barrier, and I think this is nothing new for all of the group that is present here, was knowledge and training. Most of the clinicians we are not aware that this is not a Star Wars anymore, that this is a reality, and this is something we can even implement into our day-by-day practice workflow. So we decided to join, start working together and collaborate in order to bring education and tools so we can actually work together with professionals interested in the knowledge, research, dissemination, and clinical application of personalized medicine. Nowadays, we are around a little more than 500 active members. It's an interesting group. Most of us are not clinical geneticists by training. We are different healthcare providers, most of them physicians. But the interesting part, it's a very diverse group from many specialties, which makes quite interesting discussing, for example, the implementation with different medical angles, for example. Nowadays, we have members from around 8 countries of Latin America. Let's go to the next slide. Again, one of the main goals is to foster implementation of precision medicine through training, evidence-based training, obviously. And nowadays we have this ALAMP is a free association where anyone involved or willing to involve in the implementation of genomic medicine that is focused on the healthcare sector can join. And we have nowadays for 2021 some interesting learning resources that I would like to share with you. We have fundamentals and applications of pharmacogenetics. We have pharmacogenetics applied to cancer treatment, pharmacogenetics in psychiatry, genomic tools for the study and diagnosis of diseases, introduction to whole exome sequencing analysis, introduction to genetic testing for hereditary cancer, among others. So all of those are available, are free. It's just about logging in, registering yourself and be part of the association, and you can have access to all this content. That's the main goal. It's to share evidence and to share, make more accessible the resources in Spanish for Latin American providers, healthcare providers, in order to feel more comfortable during the implementation of the genomic tools that are currently available worldwide. Next slide. So before jumping into the topic that the second part of my talk here, that is what are we doing in terms of pharmacogenomics, I would like to ask you, what do you think those 4 images have in common? To be more specific, what do you think buying an NFL football team or giving away around 240,000 full 4-year scholarships in one of the most expensive universities in the United States, giving around a lot of money for every single citizen in the United States, or even buying 60 million bottles of my favorite tequila have in common? If you can give one more click. All of them are the same annual cost of adverse drug reactions in the United States. It's the fourth cause of death. The fourth cause of death in the United States, and it's the same thing here in Canada. It's the same thing in many countries in Europe, and I'm sure that it's a very similar number around Latin America as well. So it's a problem. It's something we need to work out, and pharmacogenomics may be a good fit for it. Let's go to the next slide, please. So our strategy in terms of fostering the implementation of pharmacogenomics in the Latin American landscape, it's been through medical associations. In other words, we have been in close contact with different clinical associations, and we are trying to adapt the concept and adapt the terminology and adapt mostly the implementation to their workflow. We are strong believers that it's easier, for example, in this case, this is the biggest cardiology meeting in Latin America with more than 4,000 MDs back in February in Mexico. And rather than make them jumping into pharmacogenomics and the genomic field and the specialty details, we think and we strongly believe that it's easier bringing into their workflow, into their practice, in order to make more accessible and understandable how they can implement in the day-by-day practice. So we are partnering with a lot of associations and colleagues in Latin America For example, during this talk that we had the chance to discuss about the implications of pharmacogenomics in cardiology among or in front of 4,000 cardiologists. And then we hosted a pharmacogenomics workshop, which I strongly believe is a great way to actually enhance the implementation. What we do basically is we host this 2-hour, 3-hour PGX workshop. But the most interesting part is that before or prior the event, we tested all the attendees. So we aggregated data, and in other words, we gave them the opportunity of living pharmacogenomics in a first-hand experience. So we know it's very different, rather than saying, yes, 1/4 of the patients that will not activate clopidogrel, so meaning the risk of developing another heart attack will be increased. It's way different than saying, 3, 50, or 100 people here in this group will have X or Y variant that will be affecting X or Y treatment or drug, for example. So the results that we had received from those kind of initiatives they have been amazing. Nowadays, we've done around with the same approach around 7 times in Latin America, and we have tested more than 1,000 patients with this initiative, meaning patients, to be more specific, physicians and participants among different medical congresses. Can we go to the next slide? So just to take a look about, for example, data that we got from this group, there were 250 physicians. We found, for example, that almost 80% of them had presented an increased risk in terms of warfarin and the correlation with vitamin K receptor gene, for example. Next slide. We also found that in terms of C2C19, a very important gene that is, among others, is correlated with the activation of the prodrug clopidogrel, or it has a relevant impact of the proton pump inhibitors, such as omeprazole, for example. We found that 52% of them had an increased risk of developing an adverse drug reaction or a lack of efficiency due to the C2C19. Next slide. Same thing with hypersensitivity reactions related with HLA and HLA-V, 21% increased risk with different drugs, for example, allopurinol, carbamazepine, among others. Next slide. Same with one of the most important genes and most complex genes, that is C2D6. Around 25% of that is related with the metabolism or activation of around 25% of all drugs. And we found a 52% increased risk of developing adverse drug reactions in this group. And I think this is very important because this is a very complex gene, and we need to have information about our subpopulations. We have tested around 8,000 patients from Latin America, and it's very interesting the results that we have. And if we compare it with the information for example, from other ethnical or sub-ethnical groups, the discrepancies are quite interesting. That is worth to continue studying further. Next slide. So I think the takeaways, or closing my presentation here, precision medicine is a reality. It's a global trend, and we all know I think that's why we are here. LATAM is not an exception. It's been shown, and we understand nowadays, that precision medicine, it's a good, cost-effective proposal for LATAM and for developed countries. So, and we also know that reactive medicine isn't working. So let's try to switch from preventive, or better yet, to predictive medicine. And a very important concept is we need to generate and share local data. We need to start comparing Hispanics with Hispanics. We need to generate and share. And for example, the previous conversation was amazing, and the data that will be seen in the future from Brazil, that's fantastic, and we need to continue doing the same. And the only way we can actually raise our hand as Latin America is by working together, by collaborating. And I think this is an amazing opportunity. This is an amazing group to continue relationships and work together. It's the only way we will achieve that goal. Finally, the last slide, please. I would like to quote Sir William Osner, that we know that the good physician treats the disease, but the great physician treats the patient. Thank you.
Thank you very much, Bernard, for your presentation. So next speaker is Catherine Marcelin from Universidad de Chile. She's going to talk about the development of an actionable NGS cancer panel in or for the Chilean healthcare system. Catherine, please.
Thank you, Ricardo and Gabriela, for the invitation. Next slide, please. Today, I'm going to tell you about the design of a panel for the detection of somatic mutations in tumors. Next, please. Yes. Well, during the initiation and the progression of cancer, the tumor cells acquire several mutations, hundreds, even thousands of mutations. And some of the mutations are critical for the tumor growth and for the progression of the cancer. Next, please. These mutations, or the pathways that are affected by these mutations, have become the target for specific therapies, such as molecular antibodies or inhibitors. So those drugs will block these pathways and therefore will block the growth of the tumor and the disease. But not all the tumors have the same mutations. So the current concept of precision medicine in oncology is to treat the patients according to the mutations that the tumor have. Okay, so these mutations are the predicted biomarker for the specific therapies. Next slide, please. For a good decision about what treatment to choose for the patient, is very critical to have a system to detect these mutations. Okay, in Chile, the system that is used right now is a qPCR-based system, which detects specific mutations in a couple of genes, in one or a couple of genes. That is not very cost effective, since, as you saw in the last slide, there are many drugs and many biomarkers already available. So the alternative is to use the NGS for the detections of many mutations at the same time. Okay, so we have these medium-sized panels that detect around 50 genes and that are biomarkers for several drugs. As far as I know, in Chile, we have only one clinical laboratory that is offering this kind of assays. Okay, we have also the alternative to use big panels that detect around 300 genes. That's the case, for example, the most popular one used in oncology is Foundation One, that is made by American laboratory. And I don't know if you can see the down, but I don't know. Okay, those kind of panels, this big one, 300 genes, are definitely the most comprehensive panels and give you the better information to make decisions, clinical decisions. However, is very expensive. The price is prohibitive, basically, for people like in Chile. The medium-sized panels are a little bit cheaper, but they're still very expensive, and only few people can afford it. In economies like Chile and Latin America and other economies like our country. So if we want to implement the precision medicine in oncology, we have to start lowering down the prices of the testing. Okay, next, please. Thank you. So this is possible because although you saw a long list of genes that can be detected and are associated with therapy, only 18 genes are validated and recommended as biomarkers by the FDA or the clinical guidelines. Okay, so we designed and validated a small panel of genes, 25 genes, adapted to our local needs. Okay, next, please. This is the panel. We call it tumor-seq, and we use hybridization capture method for library prep. Okay, you can see the genes that are biomarkers, and also the drugs that are associated with that biomarker, and the tumor type where the biomarker was validated. And in the evidence column, you can see that most of these biomarkers have level of evidence A and B. That means those are biomarkers that are for drugs that are standard of care. Okay. Next, please. We first optimized the protocol and the bioinformatic pipelines for the detection of the mutation in formalin-fixed embedded tissue. Okay, because this is the kind of tissue, or FFPE, this is the kind of the way the tissue is preserved in the hospital, and it's the tissue that we will have available in the hospitals. Okay, next, please. We also perform several validation analyses following the recommendations of the American Association of Molecular Pathologists. For example, we detect the analytical precision. For that, we use a commercial DNA that has known mutations with frequency, known frequency also. And on the left, you can see this is the DNA that has mutations, as I said. We have the expected frequency of the mutation and the frequency of the mutation that we got with the assay. And on the right is the same, but only for one gene. This is the breast cancer susceptibility genes. Sorry, but for two genes. Breast cancer susceptibility genes BRCA1 and 2, because they are also included in our panel. And you can see that we can detect the mutations very precisely. Next, please. And next, we also checked for the repeatability and reproducibility of the assay, and we got 100% of concordance. Next, please. So using this assay, we check for mutations in 7 samples from different kind of tumor, like breast, gallbladder, colorectal, ovary, and other kind of tumors. And we detect mutations in 20 out of the 25 genes that we analyzed. Next, please. Also, we know that implementation of this kind of technology in a hospital or in a clinical setting is very challenging. Something that can be even more challenging is the implementation of the bioinformatic analysis. So we implement this bioinformatic pipeline using open source tools, okay? And this pipeline is almost completely automatic, runs almost automatically. And importantly, this pipeline generates 2 kinds of reports. One is a technical report and also a clinical report. And next one, please. This is an example, is the first page of a technical report. Okay, and in this report, you will find all the information with all the sequencing metrics important to take a decision about the quality of the sequencing. Okay, like uniformity and coverage and target region, coverage on target region, etc. So you can decide whether the quality of the sequencing is good enough to make a clinical report. Next one. And we design a platform, it's a web platform where we generate a clinical report. Sorry. This report is meant to be given to the oncologist, so it has only the information that is relevant for the oncologist to make a decision about the treatment for the patient. Important is this report is in Spanish, That's something that is very important for our clinicians and probably for most of the Latin American countries also. Next one. Finally, this is all the people that work in the project and all the financial support we had. And very important for us is that the Instituto de Salud Pública de Chile, or this National Public Health Institute, is part of this project. So the idea is that they can provide this assay for the public hospitals once the pandemic is over, of course. Okay, that's all. Thank you for your attention.
Thank you very much, Catherine. So now we're gonna do a slight change in the program. We're gonna invite Cecilia Rodriguez from the Patients Alliance in Chile to talk about patient participation and advocacy. Cecilia, please.
At least in Latin America, good morning. Thank you very much for the invitation. It's difficult to speak after specialists have spoken about such difficult things as genomics and maps, and I came to speak to you about something very simple, but not because it's simple, it's less important. So let's go with the slides. Next one, please. This is a number that we as patients would like everybody to remember. 99% is the time that it estimated that a patient lives away from health systems, away from health specialists. 99% of the time is the time that me as a patient have to spend realizing by myself or with my family and my loved ones how to deal with a chronic condition. 99% of the time I need to self-manage my condition. So why this number is so important? Because when it comes about, many times when we patients want to participate from some process, people tell us, but what do you know? I know how to live with a disease. I have the experience of living with a disease. So all the maps, all the genetics that we can view in graphics, a patient is the lived experience of those maps. How that impacts daily life, how that impacts decisions that we make. A patient is the one that can bring the preferences and values to a conversation. And many times we have, this experience is not validated as a knowledge, as a valid knowledge. But I want to show you why this is so important when building systems and more robust systems. Especially after this COVID experience, we will need to build more robust systems, health systems. The next one, please. I wanted to bring this definition. I think this was one of the last Congress made where people were gathered together. This was in February of this year. And why I value so much this these definitions. For many years, we have been talking and listening about patient empowerment and patient engagement. But Helen Haskell from WHO this February introduces a concept that is very used in other areas, not in health, but in other areas, that it's co-production. So now we have these 3 different stages that are very important when it comes to involve patients in decisions or in policy making. Patient empowerment is about patient leading with their own condition and what is needed. Patient engagement is a relationship that it's what we need to start to build and involve people in how healthcare is delivered. And co-production is an interactive process. And Helen Haskell said in this meeting that it is the foundation for improvement in healthcare. The next one, please. So, if we have empowerment, engagement, and co-production, where can patients participate? Where we should have patients participate? In research. Why in research? We can define outcomes, express problems, express concerns that can be solved through research. Also in peer education, it has come that all the systems that are working in education have noticed that when a peer educates another one, it's a much more valid information. It's something that comes from somebody that you suppose understands you fully. It's like, if you live what I live, I completely believe you. That's something very curious, but it happens. In policymaking, because we know not only about our disease, but about the system. And now with COVID, we have experienced that. Things that we have been asking as patients for the last, 3-5 years, are things that now are being implemented because it results to be a better way of delivering care to patients. We experience the interchange with the system daily. So that is also a knowledge that can be used, and very well used, when it gets to design policy. And the last thing that patients can be involved is in accountability. We have, for example, a law that provides patients with high-cost drugs in Chile. And it's very important that patients participate from that committee to evaluate if the law is being well applied and if it is working for everybody. So patients can also transparent process for the community. And that is very important when complex policies, complex processes are being made. Next one, please. And what things are really, 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 if we want to get to the goal, if we want to get things done, these are, for me, 2 key issues when it comes to patient participation. We need to define and measure outcomes with patients. I have the example I have a rheumatic disease, and high-cost drugs were developed to manage this condition, but it was not developed with patients. So even though the world has invested a lot in biologic drugs to control rheumatoid arthritis, patients still report that fatigue, it's about 64% of patients that report that they still live with fatigue. And why is that? Because drugs were not made to control fatigue. They were made to control pain and to control inflammation. And those were issues that clinicians were concerned. But the voice of the patients was not included in these outcomes. So it's very important that we can define and measure outcomes with patients. And the second key issue is evidence. Because we know that we have a gap in understanding all of what, for example, in this case, I was so amazed listening to all the other presentations, trying to learn a little bit. Yeah, but we don't know about all this stuff. We don't know necessarily about evidence. So evidence needs to be made in the right format and on the right time. It's not about not giving evidence to patients when they participate from policy making process, but it's about to give the evidence in a format that can be easily comprehended. The next one, please. This is a cycle of engagement that the UK developed a couple of years ago, I think 4 years ago. And I think it's very interesting that it's about engagement. So it's about, you can see design, approve, monitor and learn, analysis and plan. It's a continuous cycle where you can involve not only patients, but communities. That's very important. But it's interesting that 4 years ago, everybody was speaking about engagement. How we use participation to engage patients. But we were not still speaking about co-production. So I think we have, I forgot the word in English, a desafío, something new to create, and I hope there's interest in this group to create a new cycle, the cycle of co-production. The concept is recently incorporated in health and in participation, but we still do not know exactly how we can co-produce knowledge. How can patients we involve in the co-production of knowledge and policy also making? McMaster University, they have a program, they have developed many tools so that community can be involved in policy making. They are available, and I think it's needed so that we can go quickly 2 steps ahead. Next one, please. So just to be finishing, more efficient and effective services and more centered person care can be delivered if we listen to people. I think one of the important knowledge that we have been trying to share with decision makers is that you don't need to imagine what a patient will feel, what a patient will want. It's just about talking and not imagine. We can listen and we can know better what patients want. And more through the world, patients are being organized in groups, in advocacy groups, so that now it's even easier. You don't need to find a patient on their own, but more and more groups, even for rare diseases, are being created and are being advocated, and so we have a new tool. And patients, we are really willing to cooperate with scientists, with policymakers, with decision makers. We want to make health better, not just for one, but for everybody. And I think the pandemic is making a huge opportunity to collaborate and to make this co-production with patients and with others happen faster than we even imagine. So thank you very much. And the next slide only has the contacts if somebody needs them. Thank you, and thank you very much for the invitation.
Thank you very much, Cecilia. And so now we're gonna go ahead with Meb Dominguez Valentin. She's from the Institute for Cancer Research at Norway, and she's gonna talk about the Latin American Hereditary Cancer Network. Please, to all the speakers, help me with staying within your 10 minutes time blocks. So please, Meb, go ahead.
Thank you very much for the invitation. I would like to thanks to the organizing committee. I will talk in the next 10 minutes about the Latin America Hereditary Cancer Network. I have been coordinating Latin America study during the last 15 years. The next slide, please, is about the outline of my presentation. I will focus in the next slide about the most common hereditary colorectal cancer that is called Lynch syndrome. I will talk very briefly about our studies in Latin America, international research collaborations, our publications, the database, funding, networks, and educational programs and diffusion. Next slide, please. As I mentioned, Lynch syndrome is the most common hereditary colorectal cancer. As you can see in the slide, the distribution of colorectal cancer cases by familial background, up to from 5% to 10% are hereditary cases. The next. I will focus about Lynch syndrome, the next one. That is, as I mentioned, the most common one. Why? Because out of 30 colorectal cancer, one is Lynch syndrome. Lynch syndrome is caused by the presence of pathogenic variants in the mismatch repair genes, MLH1, MSH2, MSH6, and PMS2. Next one. As we don't have so much time, I will talk briefly about our first South America collaborative molecular study in Lynch syndrome. It was started in 2006 and was based in a collaboration between Brazil, Uruguay, and Argentina with the aim to characterize the presence of genetic variants in MLH1 and MSH2 in patients that have suspicion of Lynch syndrome. We performed this study in more than 100 patients, and our study was so far the largest and most integrative series that have an impact at regional level. Our study provides information about pathogenic variants in these two genes that have not been previously described in other populations. It was around 35% of novel pathogenic variants. We also have described what they called a hotspot region located in exon 13 in gene MSH2 in the Brazilian population. This study was the basis for the implementation of the genetic testing that is now established in the Hospital AC Camargo Cancer Hospital in Sao Paulo, Brazil. Next one. As I mentioned, I don't have time to go through all the studies. This is the last publication, next one, that we have, that it was printed last year, in the middle of the year, that we did as international survey across most of the country from Latin America in order to know which is the current genetic testing practice in Lynch syndrome. I can mention that we also can apply this knowledge to other hereditary cancer like breast cancer or ovarian or lymphoma, because most of the centers participating in our study are performing also genetic testing analysis for these syndromes. As you can see in the figure, in the map, where all the participants, in total 33 centers, participated in our survey. Just to mention, the green stars are the countries that are currently performing genetic testing. So far, in our knowledge, 2 countries like Bolivia and Paraguay are not performing. Next one. It means that 87% of the participant centers belonging to 9 countries from Latin America are performing genetic testing according to our survey. Next one, please. And these studies that we have started more than 14, 15 years ago allow us to provide the description about the Lynch syndrome profile in Latin America population. As you know, most of the studies in cancer, hereditary cancer, have been described in Caucasian population, but not in Latin America population. In 2018, we described for the first time the Lynch syndrome profile, including population from Argentina, from Brazil, from Chile, Colombia, Mexico, Peru, and Uruguay. And the important information that we described in this article was about the profile, the presence of pathogenic variants according to the most affected genes. Just to draw your attention, Colombia have more presence of pathogenic variants in gene MSH2. It's more common as in the other countries to have in the gene MLH1. Brazil have a high incidence of pathogenic variants in the gene MSH6. Why this information is important? In order to implement genetic testing in low settings country. Instead of start the whole analysis of all the genes, we can start, for example, in Colombia with MSH2. In Brazil, why is important to know that have a high incidence of MSH6? Next one. Because we have described it in our prospective Lynch syndrome database that the presence of pathogenic variants for each gene result in different and precisely known cancer risk. It means that, for example, in our last study, we described that pathogenic variants located in the gene MLH1 and MSH2 cause high risk to develop not only colorectal cancer, but also endometrial cancer and ovarian cancer. Pathogenic variants in MSH6 genes cause a high endometrial cancer risk. It means that women with Lynch syndrome need to be screened for endometrial cancer. Our prospective Lynch syndrome database, PLSD, have the aim to provide personalized medicine for Lynch syndrome patients. Next one, please. I will talk briefly about our next one, international research collaborations. In 2013, we started our collaboration in order to identify, as we have identified several variants in the mismatch repair genes, and this variant was for the first time described in our population. They were not available in other population or in database. We started this collaboration, next one, with the University from Frankfurt, and in this publication, we provide evidence from different perspectives, from family history, from biochemical analysis, from bioinformatic analysis. We have analyzed these variants located in the gene MLH1, next one, and we in this study propose the classification for these variants. Why is important this classification? In order to provide a genetic counseling, not only for the patient, but also for the family members. Next one. Our last study, published 3 days ago in familial cancer, was also to identify or to try to interpret the significance of the variants located in the intron area of MLH1. This variant was described in Argentina, Chile, and Brazil population. We have performed segregation analysis, mini-gene assays, RNA analysis, and we join all the evidence, and we suggest that these variants are pathogenic or likely pathogenic. Next one. Next one. As I mentioned, we have so far as a Latin America hereditary cancer group, more than 20 publications. Next one. Based in our survey, we have more than half of the center report that are performing research study. Next one. And based in all our studies and description, we got an email from Henry Lynch, that was the medical doctor that described this Lynch syndrome, recognizing the studies that are performing in Latin America. Just to mention, he went to Uruguay in the 70s in order to provide support for the future genetic testing analysis. Next one. Next one. Based in all the description and our studies, inside the International Society of Gastrointestinal Tumors over the world have provide an interface about variants from Latin America in the mismatch repair genes. As I mentioned, these variants were not described in other population, and for that the interest in support this interface for us. Next one. Next one. Regarding fundings, we here from Norway, Oslo University Hospital, we have the aim to build capacity between Europe and Latin America, and we have applied for funding in the European Union, next one, to support the implementation of the prevention genetic testing in hereditary colorectal cancer. Next one. Also, we have been applying not only at European level, but also at North America and within Latin America for fundings in order to continue this study. Next one. Next one. Our international networks not only include Europe, but also, as I mentioned, United States, Finland, and also Australia. According, next one, to our survey, more than half of the reporting have described that have already collaboration not only within Latin America, but also with Europe, USA, or Australia. Next one. Next one. And regarding the educational programs that we are performing in hereditary cancer field, it was started some years ago the e-learning course in cancer genetic counseling by Clínica Las Condes, Dr. Francisco Lopez and Karin Alvarez. This is a priority initiative in Latin America, next one, that with the aim to provide specialized training to oncology professionals, next one. This was started at regional level, but now is implementing across Latin American countries. Next one. And finally, the diffusion. We are performing not only the diffusion at scientific level, but also in the media from the members of our Latin America network. Next one. And well, I'm ending my presentation with some conclusions from our study that still there are countries that have not implementation of genetic testing. And next one, I would like to invite also to visit our website about the Latin America Study on Hereditary Tumor Group. And finally, I would like, next one, to acknowledge the collaborations, the collaborators from all the Latin American countries to be able to make these studies and research. Thank you very much.
Thank you very much, Med. And now we're going to move to the next speaker. She's Silvia Castillo from Hospital Clínico Universidad de Chile, and she's going to talk to us about education and workforce. Silvia, please.
Okay, I was thanking for inviting me and congratulating the organizers, because I think the diversity of subjects treated makes this meeting so entertaining, like genetics is. I want to talk about something more specific, more dogmatic. Next slide, please. We all agree that genomics is a key driver to improve healthcare in multiple ways, and that education and training of healthcare professionals is fundamental. This could start now with the inclusion of a family history of diseases in every medical consultation, for example. Next slide. What about clinical genetics in Chile? We are 33 active clinical geneticists. This means around 1 for 500,000 inhabitants. Still, there is only one training program for a specialty, and genetic counseling per se is not a recognized and rented activity. We deal with all areas of medicine, and as an example, hereditary cancer is an issue where preventive measures are pivotal, or pharmacogenetics is also an important, very important issue. There are 15 clinical cytogenetics laboratories, 3 molecular diagnosis labs involving a limited number of genetic diseases, and 6 molecular pathology laboratories. We use international tests for those who can afford them, and there are also some exceptional possibilities in the public system for doing that. Next one. About the training program in clinical genetics, it lasts 3 years. It includes basic courses in molecular genetics with emphasis in clinical practices with ethical considerations. Students rotate through many different genetic services. Rate of new graduates is 0.7 per year, but in the last years, the number of residents has increased, and the students have destinations extended through all the country. Other specialties rotate in clinical genetics for some months. Next slide. Because 78% of geneticists work in the metropolitan area, because congenital anomalies are the second cause of infant mortality, and because there's a national registry of congenital anomalies in all newborns, mandatory since December 2015. Telemedicine emerges as an assistance and education tool. We can support the Ministry of Health in its network, and actually clinical genetics is included during the COVID-19 epidemic as a telemedicine service. Next one. We have some experience with perinatal interconsultations for an existing national net of live and remote sonographic examinations for women with fetuses with congenital malformations. And we have made proposals for remote consultations for hospitalized and outpatients to optimize the care and help in diagnosis, test suggestions, and possible referrals. We have some preliminary experience with neonatology services and teaching essays with clinical genetics residents from various countries. Next slide. We have collaborated in developing a roadmap considering genomics in health services, generation of new knowledge, public education, legal regulation, and international collaboration. Next one, please. OECD reviews of public health in Chile consider cancer, obesity, tobacco, and genomics as central items. Next one. They recommend that we should develop a national precision medicine strategy to make a framework for personal genetic data protecting individual privacy, establish quality assurance for genetic analysis, and increase genetic literacy amongst health professionals and the public. Thank you very much.
Thanks a lot, Sylvia. So now we're gonna move to a panel discussion and start with a general question that we have for all the speakers to reflect on in terms of based on their own experience and based on what they know about the system across different countries. Maybe if we can comment and pick one major topic to develop on implementation. What's the major challenges that you have? Maybe we can start with in the same order with Ligia.
So the major challenge we had was funding. We've been talking about doing a Brazilian genome project for many years, and the reason we didn't start before was funding. And that's why I decided to go after the private sector as philanthropy. You know, the private sector sponsors arts and shows and everything. Why not science? And given the sort of a national project of characterizing the genetics of the Brazilians, it was the first time I did that. So this was a challenge, but it paid off, because once the project was up and the government realized the importance, they came along and took over and increased that funding tremendously.
Thank you, Ligia. Maybe Bernard?
Yes, I think number one, indeed, funding for Latin America is critical. Costs, it's a major barrier in order to a proper implementation. But I will add also education and training. I think it's a critical component as well. I think that the clinical genetics or the genomic field is a very fresh, new medical field, and most of us, even specialists of subspecialists, we are not aware about how we can use that. I mean, outside the clinical geneticists, there is a very lack of knowledge of the tools, resources, implications, and where can we and we cannot use the genomic tools. So I think there's a major need to connect the experts in the field with the other providers in order to help them to understand how to use it and implement genomic tools into their workflow. So I think the two main aspects, indeed, number one will be cost or funding for research, and training and education for providers.
Thank you, Bernard. Mev, maybe what's your experience on this topic?
Well, I also in line with Ligia and Bernardo, and also just to maybe add about also the distribution of the human resources and technology. In our experience, in our study, we have identified the resources, mainly technology or trained human resources are located in the capital or in the main cities, and not in another city far from the capital. And also about the healthcare insurance. In most of our countries, we have the private system and the public system. And this is also, I think, one challenge that we are facing. And also the own regulation of each country. This is very different. We are very different between the countries, and each of us have different regulation that we need to take in consideration when we want to implement genomic medicine.
Thank you, Mev. I know Cecilia has to leave, so Sylvia, please, if you can share your thoughts about this.
Sorry that Cecilia had to leave, because I want to stress that the patient is our center, and it is the most important. And I'm so happy that of the empowerment of the patient alliances, and that they collaborate and unify to develop research, and to maybe not only relieve, but find some solutions for rare diseases, for example. I think that for the extension of genomics, the most important is teaching. When you mention, for example, pharmacogenomics in a medical group, all want to know more about and want to ask for those tests. People don't know or are not aware. So that's something we can do internationally, we can do online, and we can start now.
Thank you, Sylvia. Catherine?
Yeah, of course, I agree with the funding thing is essential, but I think in oncology is a little bit different, the condition, because we have more challenge. Sequencing tumors is more expensive than sequencing germline DNA, no? So that made the testing for precision oncology very expensive. That's why I think there are not laboratories offering this test, okay? So we need the presence of the government and the decision of the government. And that is not very easy, because also the identification of those biomarkers to define what's the best therapy for the patient also implied that the therapy has to be available. And these are expensive drugs. And of course, in our country, I know Chile is an exception among even Latin American countries, where patients have to pay for the therapies, for the test, and for everything. We have to pay for everything, basically. So it's very hard to implement this kind of technologies. And also, as I mentioned, I think that bioinformatics people, education in genetics, education to the clinicians. They still need more education in genetics, and also to have the bioinformatic capability, people trained, and also the informatic itself. I think those are the key points. Mm-hmm.
Thank you, Catherine. So I'm looking at the chat to select some question, and I see a topic that maybe is for Bernard and Mev, if they have seen any trend on how ancestry or difference across not only across countries, but also if ancestry is impacting heavy the observations that they have. Maybe Bernard can comment on that.
That's a fantastic question, and I think this is the right place to discuss it further. Indeed, yeah, I think everywhere there's a lot of sub-ethnicities or different backgrounds in terms of ancestry. For example, most of the cases that we got are from Mexico, and as you are aware, there's a lot of different ethnical groups and subgroups back in Mexico. And if you compare, for example, the group from the north with persons from Yucatan, which is the southeast of the country, it's very different. And you can see it, in preliminary results, just for example, with genotyping CYP2D6, a very common enzyme or gene related with the metabolism of several drugs. You can see the difference between even the activity. I mean, the genotype and the phenotype implication of that allele score, for example, it differs per group. So yeah, and I think that's why during my presentation, during my closing, to be more specific, I said that we need to continue working together, and we need more evidence in terms of pharmacogenomics. Even pharmacogenomics, I'm going to say we are not yet there. We need more information from the sub-ethnicity perspective.
Med, in your experience, thank you, Bernard.
Well, we have been described in different populations. We are aware about the genetic background difference between Bolivia, Brazil, Chile. We have identified in our studies some potential founder mutations in mismatched repair genes, but this is one of the next goals of our study in order to analyze the ancestry. That this is really interesting, and we are aware that it must have an impact.
Mm-hmm. And then another question, if any of you, I believe maybe for Bernard and Silvia, have experience in the region with the use of clinical decision support tools. Is that something that you see in your clinical practice? So Silvia?
You mean for tools for diagnosis? I don't know what they.
For example, if you, I don't know. I've seen other systems that if you have an electronic chart and your patient has certain age, certain history, maybe the chart will suggest you to consider some testing or things like that. Is that something that is available in Chile? I believe it's not.
No, maybe not so, but we use always this kind of information for going in some direction. For example, some important signs and symptoms, or using this international nomenclature for describing these signs and symptoms helps to go in some way to think about a diagnostic hypothesis. I think we are always using these tools that exist in the web, or that are based on information of multiple patients and cases. Maybe not a specific one, but in general, that is our way of working. Yes.
Mm-hmm. Thank you, Silvia. Maybe Bernard, that you have the experience from Mexico and Canada.
Yeah, well, I think I'm gonna even jump it outside. I'm gonna say worldwide. The reality is that I don't think we are there yet. I think we do have a lot of tools in terms of how to that will help us in implementation. But the question is, where are those tools? I mean, where are landing those tools? Most of them are, inside the genetic group, right? Meaning us. So we need to figure out how we can connect and communicate with the rest of the specialties in order to help them implement that. Most of the time, even in oncology, they are using a lot of more genomic data than the rest of us. They are not aware about the current guidelines, for example, the ACMG is working around X or Y gene, or for example, cardiologists in terms of C2C19 and the implications of clopidogrel, for example, or warfarin or whatever. The reality is that we need to work with other groups in a more dynamic way in order to a better implementation. So answering to your question, I think we're not yet there.
Mm-hmm. Thank you, Bernard. So, I think just for a last round, and I know that Cecilia had to leave, but maybe we can reflect on how we imagine that patient and advocacy plays a role in genomic medicine implementation. I'm going to start with the clinicians, maybe Sylvia and Bernard. How do you see the role of patients on the research and on the implementation?
Do I start? Yes?
Please go ahead. Sure.
Okay. Well, I have seen during my long career in genetics a great move and change in how patients deal with research. What I was saying at the beginning, I see that they are looking now for scientists, and they are interested in collaborating and looking for others similar to them to make a more great group to achieve more results. So I have lived it in my professional life that patients, organizations invite scientists from overall, and each one tells what he's dealing with or advancing, and they invite the physicians themselves, and so that we also learn and get aware of how advances are. So I think it is a very important issue, and also it is an empowerment of the people that need to be empowered.
Thank you, Sylvia. I was going to skip Bernard for a second and ask Ligia, do you have somehow people, the society represented in your genomic initiative?
No, not yet. We're still organizing that, but we don't have that yet.
Mm-hmm. But that's something that you're considering.
Yes.
Okay. And Bernard, sorry, back to you with your experience at the
Yes.
research arena and the clinical arena, patient's role.
I think the previous response from Sylvia was fantastic. I think patients are the cornerstone of this new reality, of this new trend in medicine. At the end of the day, we're talking about precision personalized medicine, and when we refer to personalized medicine, we're talking about individualized treatments, but also we're talking about the patient owning their health and their decisions and be supported by us. And most of the time that would happen with rare diseases. The patient is seeking for new information. The patient is seeking for new help, and he or she connects the dots. He goes with Dr. A and then speaks with Dr. B, and they are the ones that actually are building the connection and engaging, for example, the research and the industry. Sometimes the patient groups are the ones bringing the industry in order to help us for a better implementation. So I think this is I'm very candid, and I think we need to continue bringing the patient voice here. The patient needs to be part of this kind of initiatives, and they need to continue owning and being part of that. At the end of the day, they are the center or the epicenter of all of our efforts.
Okay.
Thank you, Bernard. I think we have a question from Terry. Terry, maybe if you want to go ahead.
I had just wanted to suggest, I didn't hear anyone mention the guidelines on pharmacogenetics from the Clinical Pharmacogenomics Implementation Consortium, or CPIC, and I was curious as to whether, I see some heads nodding, so I was curious as to whether they are known in your part of the world, and whether they're useful to you or how we can make them more useful.
Yes, that's a great question. I think we have several guidelines around the world. We have the CPIC, we have the Dutch Pharmacogenetic Working Group, and we have the Canadian group, and the FDA recommendations, right? Yeah, for example, talking about Mexico, to be more specific, I suggest my peers or my colleagues that CPIC is, at least from my personal perspective, one of the most guidelines where you can rely in order for implementation. And I've been loving discussions with Kelly Cole, the ex-president of CPIC. I know her quite well, and we are in the near future having discussions in order to bring in CPIC guidelines, CPIC approach to Latin America as well. Actually, we're discussing that for next year through ALAMP in order to try to engage on the proper evidence-based practice behind PGX. But thank you for addressing that. I think that's a great comment.
Great, and I would just refer people to their website. They have some outstanding guidelines that are actually put together by international participants. So anyone who wants to participate in that is welcome to, and they give you instructions as to how to do that.
Indeed.
Okay, everybody. Well, I want to thank you all the participants and of course all the speakers for this great session. We have a lot of work ahead. I wanna go back to Bernard and words. I think collaboration is so important, and we have a lot to learn. We have a lot to put together. So thank you very much for your insights and for being part of this.